I've been a nurse here for a very long time, but it's amazing, the longer you work, the younger you get.
Oh, wow.
Yeah, so we'll talk about like brain cells and, you know, my goodness, we don't ever want to lose any because they decrease as we get older, right? So we're going to talk about stroke today. And stroke is one of the biggest problems that our healthcare system has. It's the fourth most common cause of death in the United States. It kills around 130,000 Americans each year, and 1 American dies from stroke every 4 minutes. Okay? Most common cause of neurological disability. And in this country, almost 800,000 people have a stroke. If you look at this map, you can see the purple. The more purple the area is, the more concentrated stroke cases are, the more higher incidence of stroke. And you could see Ohio. Well, you guys know where Ohio is, but it's kind of mid-purple to dark purple in places. You could see the dark purple in this area. That's called the stroke belt, down in the southern part. And what kind of food practices do those people have? Fried. Everything's fried, everything's animal fried. So that is kind of how I remember where the stroke belt is, because probably the eating habits are not as healthy. But we have a pretty high incidence of our, I mean, it's pretty purple in that area. And I don't mean pretty purple, I mean purple. And I think that's because, especially in this area, we have we have a higher population of older folks. And stroke is typically thought to be a disease of older people, but that's not necessarily true, as we'll talk a little bit about. So this is probably one of the most important points that I want to make with this. This slide tells us that when a person has a stroke is an emergency. And the reason a stroke is an emergency is because for every minute that stroke is evolving and going on, or the person that has the stroke, loses almost 2 million brain cells per minute of that stroke. That's pretty sobering, I think, because I know where I'm at and I know what my thinking capacity was maybe 20 years ago, and I don't want to lose any more than I've already lost, because as we age, we naturally lose function. So you can see a stroke is an emergency, and there's a couple reasons that we'll get into why it's even more important to get to the hospital promptly when you have a stroke. Our brains are made up of special cells, and they're called neurons. They transmit impulses by a chemical reaction, but they get their energy from the glucose and the oxygen, and that's carried by the blood. So that's just a picture of a brain cell, and they communicate by the long fingers on the end of the cell. Blood contains the fuel for brain cell function. Blood has 3 main components. They have white cells, and the white cells usually fight infection. That's how people tend to know blood is, that the white cells go up when you have an infection. Red cells provide the fuel because they attach to the oxygen and the glucose. And then the platelets we'll talk a little bit about. The platelets are responsible for clots. So when you cut yourself, you activate, all the platelets come to the area and various other factors to make your blood clot. What happens in a stroke is that an artery in the brain either develops a clot or it breaks and it bleeds into the tissue. 87% of the time, it has to do with a blockage or a clot. And the other 13% of the time is a rupture. Ruptures are pretty rare. We usually, typically here would send you, there's different stroke centers, and we would send you to probably Cleveland or Pittsburgh to have this problem taken care of. But the majority, the vast majority, are from blockage in the circulation of the brain. Now, when we look at the circulation of the brain, this is looking from the brain from the bottom part. So if you look at the very base of the skull, there are a group of arteries that come together. And there's two, and you can feel them in your neck. Those are called the carotid arteries. Please don't squeeze at the same time on both sides. You'll pass out. Okay. But they're there, and you might hear the doctor, if you go to the doctor's office and have a physical exam, the doctor might ask you to hold his breath, and he's listening to see if he can hear any abnormalities in those vessels that might predispose you to a stroke. So about 80% of the blood is obtained from your heart circulation. 80% goes through your carotids. The other 20% goes through these vessels in the back of your head. There's arteries, and those are called the vertebral arteries. And what these arteries do is they branch out, and in some cases they come together, and they make almost a circle. And that circle is called the circle of Willis. And based on the circle of Willis, all these branches are connected to it. And these branches divide into smaller and smaller and smaller vessels. And that is what provides our brains with the fuel and the blood supply so those cells can function. This is another picture of it, and you could see in this picture, you see the circle of Willis on the bottom here, and then you could see on this side this person this is demonstrating a stroke because this artery right here, which is actually the middle cerebral artery, but you guys don't need to know that, has affected this part of the brain. But if you saw the picture before, let me go back. You can see that there's lots of opportunities for a vessel to have an occlusion or a clot because there's so many of them. And what happens, we don't know in one person, a clot in this area might affect this, and in this person it might affect a little bit differently. So everybody's a little bit different because not one of us was made exactly the same. We're like snowflakes. Not all of us were made any the same as any other one. So there's always a little bit of variation. When a stroke happens, and we're going to talk now about the ischemic stroke, or the strokes that have to do with blockages or clots, the area of the brain cannot get the fuel that it needs to function. So it starts to have a dying process, and the tissue dies. And you can see on this CAT scan, everybody can see that, right? There's an area there that you can see is different than the other areas, and that shows that the tissue has died. But what we know now is that when you have a stroke, an area of tissue is dead, and we cannot bring that back. Because that tissue's back, you can't make that tissue function again. But there is an area around that dead area, and that is called the penumbra, and that's a big fancy word. But basically what that means is that area of tissue with the dead part in the middle, the area around that can still be saved. If the stroke continues to evolve, it spreads further and further. It's like ripples in a pond. It spreads further and further out. The whole objective of stroke care, number one, is to prevent it in the first place, but number two is to get that area to have the fuel from the blood, the glucose and the oxygen, to fuel that area so it is still functional. So we have the person retain as much function as possible. Because remember, every cell every minute you're losing 2 million cells almost. And this is just going to get bigger and bigger until the whole process ends. And then if you don't get the blood supply to that injured area, that area too will die. So you might start out with a small area of death, or we call it an infarction, but it might end up to be a much larger issue, much larger area. So just if you're playing Scrabble and you have the right letters, you can use that word penumbra and you'll impress all your friends. Now the medication that we can use if you come to the hospital right away when you have a stroke, it's called TPA. And TPA is called tissue plasminogen activator. That's why it's easier to call it Activase or TPA. And it's a clot busting medication. It was approved by the FDA in 1996. But the treatment has to happen very early in the course of the stroke. So if you are having stroke symptoms, or somebody that you know is having stroke symptoms and you witness it, you need to send the person to the hospital right away. Don't call the doctor, call 911 and get to the hospital right away. The earlier we give this medication, the more tissue we can potentially save, and we get a more functional, better outcome. We have to give the treatment within 3 hours, and in some cases we can extend that out to 4.5 hours. But we get the best effect when we give it within an hour of you arriving to the hospital. I have seen TPA work great. I've seen it not work at all, and I've seen people bleed from it because the risk of giving it is bleeding. There's about a 6% chance that that area where the stroke is will bleed, and about a 3% chance that it's a bad bleed that will cause some major neurological symptoms. I have seen people, and I wish I had wood to knock on, but I've seen people. I'll give you a couple examples. My first time I ever gave it, we had a lady come in, and we didn't know back then that the earlier you gave it, we were just trying to make the 3 hours, not the 1 hour. And she was completely unable to move her one side. And after we gave her this medication, she was able to walk out of here. Yes, she used a cane, but she never would have been able to do that before. I have seen, we had recently a 36-year-old who was watching a football game, and he was drinking a lot of beer, and luckily he had his friends with him, and they were all watching the game, and he dropped his beer and was not able to speak. He came into the hospital. We were able to give him the medication in a very short period of time, and he left this hospital within 2 days, and he was 100% recovered. Okay, which 36 is very, very young to have. I mean, he could have lived another 40, 50 years with a terrible deficit of not being able to speak. So it...
How does the medicine get delivered?
Well, there's a few different ways. When you come into the hospital, or when a patient comes into the hospital for a stroke, it's always better to have EMS bring the person in, because EMS will phone ahead, they'll do a couple little assessments, and they'll actually tell the hospital, I have a stroke coming in. They call the hospital, they radio in. The emergency room doctor then can mobilize everybody, and they call a stroke alert overhead. And you might, when you're here sometime, you might actually hear that. So I will go down to the emergency room, the doctor gets ready, we get support systems, we get ready to go, and we assume we're going to give that medication. The medication is very costly, so we don't mix it up, but we get it ready to go, because it's about $10,000 a pop. Okay, but $10,000, and you saw almost $800,000 to deal with the after effect of stroke. So $10,000 I think is a bargain. But we don't mix that up until we absolutely know that we're going to use it, because we don't want to waste it. So the patient comes in, they go to CAT scan. If the CAT scan is to verify that there's not a bleeding process going on in the brain, because this medication, a side effect of it is it busts clots. It's a clot buster. So it makes your blood it dissolves the clots. It's like Drano. It dissolves the plug. And if you have a bleeding process going on, we wouldn't give it, because it would cause more bleeding and more side effects, you would think. So what we do, that's why you're getting the first CAT scan. The first CAT scan in a stroke rarely shows anything. It's just a very quick test to see whether you are a candidate for the medication. So if the CAT scan is looking normal, then we go ahead and we go through the whole process of giving the medication. It's given IV in a vein, and it's given, there's a small dose given over a minute, and then it goes into the IV, and it's for an hour, it drips in. And then you have to spend at least 24 hours in intensive care, because it's very serious. We are very picky as to who we give that to, because if you are outside of the time frame and we don't know it, and we give you the medication, we could cause some risk to you, and we don't want to do that. So it's given IV. In some cases, depending on where the stroke is, and there are trials going on all over the place, especially in Cleveland and Pittsburgh, and we do have contracts with both of them, but we could transfer you by flight very quickly, and they would, after we give you the IV TPA, they would take you right into a brain imaging lab and put a catheter, usually in the groin, go up through the arteries into the brain and try and get that clot or dissolve it right there, or actually aspirate it out, suck it out. So that in that case, they give the TPA during that process, and they give it actually in the artery in the brain. So, but not everybody qualifies for those trials, and It's all about timing, so I would rather be called, and I come in in the middle of the night. I would rather come in 100 times for a false alarm than to miss the opportunity to have somebody have a normal or a better recovery. It doesn't always work, but we want everybody to have the ability to have that chance. So I would rather, I don't care if you come in and it's a false alarm and you call the ambulance and everybody gets all riled up. I don't care. I want you to come in. I want you to come in. So in your mind, if any of these things that we talk about are happening to you, come in. We can send you home. We can always send you home. We can't make you come in, and we can't fix it once that tissue is dead.
But ma'am, do you do it here, or do
Yes, we do it here.
you run a picture?
No. We do it here. We used to not do very many. We used to probably do, I'd say maybe 6 cases a year, because people around here don't come in soon enough. Everybody's thinking, oh, I slept funny on my arm, oh, I can't see, oh, I'm just like, I've got a migraine, I have a headache. That's why you need to know stroke symptoms, and we're going to go over all this. We do it here. I would say in the last probably 3 weeks, we've given it probably 4 or 5 times. We give it a lot because now it's a standard of care to give it. Okay, we do it here. Only in very rare cases, and only some people can be transferred out.
Yes, but by the time you're transferred, isn't that time gone?
No, because we've already started the process here. We would give it to you here, and then you would continue to be monitored in the helicopter, and it takes 20 minutes to get the helicopter here and to get the helicopter to Cleveland or Pittsburgh. So that's 40 minutes. Okay.
And you give the TPA if patients are on Coumadin.
Coumadin is an issue. Any blood thinner, Coumadin is actually, it depends on what the lab work is. So we would test your lab work if you're on Coumadin. If there's enough time, we could actually reverse that and then give you TPA. Okay, now if you're on like Eliquis or some of the other Pradaxa, some of the other anticoagulants, it's very difficult because there's no parameters to test your coagulability. We don't know how thin your blood is. So you would not be a TPA candidate unless you missed your dose for 2 days previously, which you wouldn't be, or you'd probably be having a lot of issues.
Does that apply also to, say, 325 milligrams of aspirin?
No, and we're going to talk a little bit about aspirin. An anticoagulant is like something that makes your blood thinner. An antiplatelet medication like aspirin or clopidogrel or Agrinox or I'm trying to think of what's clopidogrel, the Plavix, yeah, thank you. I just drew a blank. Those medications are antiplatelet medications. So they don't work on your clotting mechanism. They work on, remember I was talking about the platelets? They make those slippery so they can get through blockages easier. They can get through, it's like the pipe is closed down, and we're gonna talk more about this, but it makes them able to slip through tighter spaces easily. Okay? So as I said with TPA or Activates, the best outcomes are when the medication is given as close to the onset of symptoms as possible. And the criteria is very strict for administration. Actually, in February of last year, they kind of changed their criteria around, so it's actually more, it allows the practitioner, the neurologist, to make those decisions as to whether somebody gets treated. So it's not an absolute rule that you would be like ruled in or ruled out. It's all, it allows, and in our institution, it's the neurologist. It allows the neurologist to make the judgment call whether you qualify for this med. And the DOTE is weight-based. Ladies, this is not the time to like tell me that you weigh like 30 pounds less than you do. And we're going to weigh you anyway. So you want to make sure you get an adequate dose. It can cause bleeding, and if the bleed is in the brain or in a place where we can't see it, it can cause death. But it is now the standard of stroke care. And even if the stroke stays the same, this medication is considered a success, because remember, if we have a clot and we have that area getting bigger and bigger, if it just stays with how the patient came in and it doesn't get bigger and bigger, that's success, because we have stopped it in its tracks. So you can see on this picture, the first picture on, I guess it would be, yeah, the left-hand side, you can see in this area, there's no circulation with the dye. And when you look over here, after the medication, because we've given the medication and we've dissolved the clot, look, all that area now is getting the energy that it needs to function, because the blood is getting there and it carries the oxygen and the glucose to that area. Another treatment, and this would be something that we would send you to Cleveland or Pittsburgh for. This is a stent, and I'm sure you've all heard of stents in your heart arteries. They can actually do that with arteries in your brain. Okay, very tiny little springs that hold that vessel open after they suck the clot out. So you can put, well, I can't and you can't, but a neurointensivist or an interventionalist can put these springs in, these stents, into arteries of the brain to keep that artery open to allow that blood to get through to the tissue. So some of the other treatment, say that the stroke cannot be treated with TPA for whatever reason. Maybe the person got here too late, maybe they have some medical problem that it's contraindicated, maybe they're on an anticoagulation medication that we cannot give it. There are still other treatments, they're just not as effective. We give antiplatelets and usually aspirin, and then depending on the issues, we can give you stronger antiplatelet medications, and those again make the platelets slippery so they don't get caught in that vessel that's has atherosclerosis on it, and platelets kind of get caught. They can kind of slip past that and slide to their destination. Another treatment that we give, we always check patients' cholesterols, and we give statin medications. Statins are thought to stabilize the blood vessel. We will also do therapy, whether it be physical therapy, occupational therapy, or speech therapy. Some people have risk factors that they might have an abnormal heart rhythm called atrial fibrillation, or a blood protein issue, an autoimmune issue, maybe a Leiden factor 5 or some kind of what we call a blood dyscrasia, and that patient might require anticoagulation. And we always tell people to eliminate risk factors. Because once you've had a stroke just doesn't, the whole process doesn't just happen in the brain. It can happen in your heart, it can happen in your legs, it can happen in any vessel that you have. So if you've had a stroke, you're, number one, more prone to strokes, and number two, you're more prone to have other problems with your arteries, so we want to keep that all in balance. The best thing to do is to prevent the stroke in the first place, but we can't always do that.
What is the anticoagulation?
The anticoagulation keeps the blood from clotting. When we have people with, say like atrial fibrillation happens in the heart. And the conduction of the heart, your heart has electrical conduction, and it is not optimum. So what happens, instead of a nice steady beat, the upper chambers kind of quiver, and they don't pump that blood to the lower chambers and get it out to the body. And I'm really simplifying this, but that blood stays in those upper chambers. The upper chambers fibrillate. They don't pump like a good squeeze of the muscle. They kind of just like jiggle, and that blood gets old. And when blood sits and doesn't move, it tends to clot. So when you have a clotting process in your body, that's when you would need to have an anticoagulant.
Is it a pill or?
It's a pill. Well, it can be a pill. We can give anticoagulation IV also. So most people that have atrial fibrillation or a Leiden factor 5 or other blood problems that have an issue with clotting are on a pill long term. Sometimes in the hospital we give you IVs or a shot to get you started, but then you're usually on a pill for maintenance. And Coumadin is one of the pills that's an anticoagulant. So you need to get your, I'm sorry?
So it's a blood thinner?
It's a blood thinner. Yeah, it's a blood thinner. So that's always, a balance to get your blood thin enough to not have a problem, but not too thin so you're not bleeding everywhere. But better, all the better if you can prevent it happening in the first place. So the way we look at stroke symptoms is we look at a mnemonic, we look at letters, FAST. And that helps cue us as to what behaviors happen when we have a stroke. So these are symptoms. So F stands for facial sagging or asymmetry, especially when like half the face looks different from the other half. A is for arm and leg or leg weakness, especially on one side of the body, tingling, paralysis. S, speech is garbled, or maybe the person is unable to speak at all. And then T stands for time to call 911. So when we teach people to recognize stroke symptoms, we teach FAST. So F is face, A is arm or leg, S is speech, and T is time to call 911. So what are some of the risk factors that have to do with stroke? Well, the cardiac arrhythmia that I was talking about, the atrial fibrillation, that is one of them. And then coronary artery disease, because if you have vessels in the heart that are getting clogged with atherosclerosis or plaques, then that process can also happen in the brain. If you've had a previous heart attack, by the same reasoning, that predisposes you to a stroke. Cigarette smoking, hyperlipidemia, high cholesterol, a family history of stroke or a TIA, hypertension, which is high blood pressure, diabetes, obesity or a sedentary lifestyle, so somebody that's a couch potato, a use of hormonal contraceptives, and we see this in mostly young women who come in, and I had, actually, this has been a couple years, but an interesting case. They have implants now that they put in the arm that are contraceptive devices, and we have to remember as practitioners, we ask, oh, are you on the birth control pill all the time? And people say no, but we don't always ask. I mean, now we do, but you know, when they started to first do the implants, that was something we had to change because a lot of women are having the implants that are put in, so they don't have to do it, you know, take their medication daily. So we want to make sure that we address that because sometimes that medication will predispose somebody to a stroke as well. Sickle cell disease is one, and gender. Men have a higher incidence of stroke until women reach menopause, and then it kind of equals out. Okay, so first of all, smoking. And you guys know this, don't smoke, right? I mean, easier said than done, though. Smoking changes the elasticity of the walls of the arteries of the blood vessels. So the little microscopic changes from smoking cigarettes causes this blood vessels to change and makes them, it's like a rubber band that gets stiff. Have you ever had a bathing suit that you put away for a long time and you get it out and like all the elastic, you stretch it and all the elastic breaks? Same principle.
What about smokeless tobacco?
Smokeless tobacco, they have not done enough studies on that. I just don't think, do you mean like chewing? I'd have to look at that. I'm not sure that there's data on that, not that I've read lately.
Poison as far as I'm concerned, but.
Well, yeah, I don't, and also the vapor cigarettes, e-cigarettes, I don't think that all the data's been out. I know that the nicotine, I'm trying to think, the nicotine in the smokeless tobacco chewing, it can't be good for your vessels. It cannot be good, now that I'm thinking, can't be good. Okay, so the next thing that we worry about is blood pressure. Does everybody know their numbers, their blood pressure numbers? You're looking at me like, No, you need to know your numbers, so you need to know your blood pressure, okay? The top number is the amount of pressure that is exerted on the arteries when the heart is beating. And then the bottom number is the amount of pressure that is exerted on the arteries when the heart is at rest.
What are good numbers?
Well, we're going to talk about that. Thank you for asking. Normal blood pressure is now considered to be a top number less than 120 and a bottom number less than 80. So the top number is called the systolic blood pressure and the bottom number is called the diastolic blood pressure. So if you have a blood pressure of 120 over 80 or less, congratulations.
Yeah.
But I'm betting that there's not a lot of you here that have that. No. And it's years ago, we used to say, oh, my blood pressure was 140 over 90, I'm like borderline. No. That's going to get you medication now, probably. High blood pressure is now considered to start with a top number of 120 to 139 over, or a bottom number 80 to 89. So then stage 2 would be a top number of 160 or higher, and the bottom number of 90 to 99. And then what we would consider a crisis or a very high blood pressure would be a top number higher than 180 or a bottom number higher than 110.
Is it worse to have, which is worse? The higher number out of line or the lower number out of line?
Well, it used to be, okay, so if you go to the doctor and you get your blood pressure checked, chances are, if you haven't been there, have you guys heard of white coat syndrome?
Definitely.
Right, okay, so your blood pressure, as soon as he walks in the door, you're like, oh. Yeah, okay, so the higher number usually goes up when you're nervous, the top number, because your heart's working harder, right? But that bottom number, if you ask me to choose, I'm going to say that the bottom number being higher is probably worse than the top number being higher. But I don't want you to have either number higher. Okay? And they have these really cool things. They're called pills now that you can take, but you have to take them. They don't do any good sitting in the pill container. Okay? And, I forgot to take my pill. I hear that all the time. Or we have guys that don't like to take their pill because of some of the side effects of the medication. So it always helps, the doctor goes to school for a long time, and the internet you can read, but take his advice a little bit. I learned the hard way. They do. They usually know what they're talking about. So, if you don't like your medication, you can work with your physician and maybe make some modifications. But the point I'm trying to make is that nowadays we are much more aggressive with blood pressure control than we used to be. It used to be that somebody with like 130 blood pressure over 80 would not have medication. Now those people have medication because some of the medication is so good that it even is a heart protectant or it's a kidney protectant. So it actually is more beneficial in some ways to be on the medication. So it's much more aggressive. So other treatment for blood pressure is lifestyle changes, behavior modification, salt, watching all your diet and all that kind of thing. And then there are several medications like the diuretics, the beta blockers, the calcium channel blockers, the ACE inhibitors, all those different kinds of medication. Now we talk about cholesterol. Does everybody know what their cholesterol level is? Okay. We always want to have your cholesterol at least under 200, 215, depending on what lab you go to. If you look at the top image here, that shows you a vessel with no plaques in it. And then if you look in the second one, you can see the plaque is starting to build up, and that's from the cholesterol in the vessels. And then in the third one, you can see that there's a lot of plaque in there. And what happens is that plaque is very bumpy and irregular, so those platelets are very sticky. They're going through with the blood. The red cells, remember, carry the oxygen and the glucose. The white cells are there to fight your infection. And those clots are shaped a little bit differently. And they get caught on this bumpy surface. And they hang out there, and then some more come along and stick to those clots. And before you know it, you have many clots, and you're going to clot that artery off. And then block all the blood up to that area. So this is just another example. You can see how coated a piece of the artery can get. Now, we divide cholesterol into many types, but the two major types is the HDL, which I kind of remember by calling it the happy cholesterol, and it's the good cholesterol. It eats the bad cholesterol. And then the LDL is the bad cholesterol, and it's the loser cholesterol. And it's usually provided by animal fat in the diet, and it goes into your GI system, and it kind of hangs out there and then gets absorbed all over the body. So what we try to do is balance these two out. Would we take care of patients with stroke? First of all, if you have an LDL over 100, you're going to go home on a statin. You're going to go home on a statin. If you've already had a stroke and you come in with another stroke and your LDL is over 70, you're going to have a change in your statin. We're going to probably bump it up because this has to do with stabilizing that blood vessel, number one, but number two, that's a standard of care now, is to give statins unless there's some really, really good reason that you cannot take a statin. So I kind of remember it. I like to equate everything I can to chocolate. So if you think about the HDL and the HDL is highly dense. So think Hershey bar. Your LDL is less dense, it's fluffy. So think Three Musketeers. Because I had to give away my candy. I would show you because I was afraid I'd eat it. But if you look, a Hershey bar and a Three Musketeer weigh about the same, but the Three Musketeer bar takes up a lot more space. So the Hershey bar will eat the Three Musketeers bar. All right, so the whole goal is to keep your LDL low and your HDL high, okay? And what happens is these numbers add together to make your overall cholesterol. So if your overall cholesterol is off, your other numbers are going to be off to a certain extent as well. The next thing that I want to talk about is diabetes. And does everybody know what their blood sugar numbers are? Okay. Because we are, in this country, we have a very high incidence of diabetes. There are two major types. Type 1 is usually, it occurs in childhood, and it's when the pancreas does not make insulin. Type 2 is when the body makes insulin, but the cells cannot receive it. So it's like all the insulin goes to a little cell party, and they go knock on the door, and the cell says, no, I'm not opening the door to you. I'm not opening the door to my party. So the insulin hangs out in the bloodstream, and it cannot get into that cell. And then you have the blood, I mean, you just have all kinds of issues because then the blood sugar gets high, the blood sugar can't get into the cell where it needs to be, the cell can't metabolize it, and you end up having a high concentration of blood in the blood, or a high concentration of sugar in the bloodstream. It usually happens we call it adult onset, but now and they equate this to fast food and corn syrup, fructose, soft drinks. Now the adult onset diabetes is occurring in children. And what we do to treat this is to give medication to make the body less resistant, because you're already producing, initially you produce the insulin. You just need to get it into the party center of the cell. So we give you medication to open up that door to let that insulin get in and be used in metabolism of the cell. But as things go on and the person suffers more with the diabetes, there's usually a pretty good chance that insulin will be required. What happens is blood sugar is very obnoxious, I'll say, to the lining, the capillary, the vessel walls. It makes them not as flexible, it makes them stiff. We call that compliance. It makes them non-compliant, and also affects the nerves. So what we do is we monitor blood sugar, but then to get a big picture, we look at a level of blood, and it's called the hemoglobin A1C. Now, a red blood cell lives about 120 days. So if I were to order this blood test on you, this hemoglobin A1C, I would be able to tell what your average blood sugar has been for the past 120 days. Okay, that's going to give me a better picture than just a one-time blood sugar, because you could have had a big Coke or something and it would be high, and we want to look at the big picture as well. So everybody should know their hemoglobin A1C. Okay? So this is just another picture of this whole process. The insulin goes into the bloodstream, can't get into the cell, builds up in the vessel along with the blood sugar, and it creates problems to the vessel walls and also to anything tiny and peripheral. That's why people that are diabetic have to watch their feet. Watch their feet, monitor their feet, because it's so far away. The further away things are, that's where the problems start. So, and people usually that have diabetes maybe can't look at the bottom of their feet. So that's why it's very important to keep good foot care. Well, you could see, you know, like if you run around in your bare feet and you cut your foot, or you might have like a cut or an ulcer because the blood supply isn't good. You might see a bad spot that would get infected, and remember, your blood isn't getting down there because your vessels are kind of compromised, so the white cells can't get down there to fight the infection, or maybe they do, but you need to get to the doctor, especially. Usually everybody that goes to the doctor and is diabetic has to have their feet checked, and their eyes. The smaller vessel places really need to be checked very frequently, because you don't want to develop problems there. So we want to control atrial fibrillation. We don't want to smoke. We want to know our cholesterol numbers. We want to know our blood pressure numbers. We want to know our blood sugar numbers and our A1C, and we want to maintain a healthy weight. That is the prevention, the whole key to stroke, because I'd rather you prevent it than to bring me business in the ER. Again, stroke symptoms, we're going to review again. F stands for facial sagging or asymmetry, a face symptom. A is for arm or leg, weakness, tingling, or paralysis. S is for a problem with speech, garbled speech, no speech, inappropriate speech. And T, it's time to call 911. Well, thank you very much for having me.
Thank you.